The UK Prospective Diabetes Study. UK Prospective Diabetes Study. Multi-center. Randomized controlled trial. Of different therapies. Of type 2 diabetes, UCT, need for a long-term study. Complications of type 2 diabetes develop over decades. Protocol written 1976. Recruitment 1977 to 1991. End of study September 1997. Clinical centers 23. Type 2 diabetic patients 5,102. Person years follow-up 53,000. Funding £23 million. UK Prospective Diabetes Study Centres. Aberdeen Lillian Murchison Manchester Andrew Bowleton. Belfast City Randall Hayes Northampton Charles Fox. Belfast Royal David Haddon Norwich Richard Greenwood. Birmingham David Wright Oxford Robert Turner. Carshalton Steve Heyer Ray Holman. Mimosmithis Peterborough Jonathan Rowland. Derby and Peacock Salford Tim Dornan. Dundee Ray Newton Scarborough Phil Brown. Roland Young St George's Nigel Oakley. Exeter Kenneth MacLeod Stevenage Leigh Borthwick. Johns Hook Stoke-on-Trent John Scarpello. Hammersmith and Dornhorst Lionel Alexander. Eva Conner Torbay Richard Paisley. Ipswich John Day Whittington John Yudkin. Leicester Felix Burden. Coordinating Staff Chief Investigators, Robert Turner, Rory Holman. Statisticians, Irene Stratton, Carol Cole. Z. Yamada, Heather McElroy. Modeler, Richard Stevens. Epidemiologists, Andrew Neal, Amanda Adler. Diabetologists, David Matthews, Valeria Frigge. Biochemists, Susan Manley, Ian Ross. Administrators, Philip Bassett, Susie Oakes. Retinopathy Grading Center, Eva Conner, Steve Aldington. Health Economics, Alistair Gray, Maria Ray Koo. Grant Applications, Ivy Samuel, Carolyn Wood. Computing Support, Ian Kennedy, John Vniss. And many others. Acknowledgements Patients Physicians Nurses Dietitians. Retinol Photographers. Retinopathy Grading, Hammersmith Hospital. Biochemistry, Diabetes Research Laboratories. ECG Grading, Guy's Hospital. Major funding bodies UK Medical Research Council. British Diabetic Association. UK Department of Health USA National Institutes of Health, NAE, NIDC. British Heart Foundation Wellcome Trust. Novo Nordisk Bayer Lilly. Bristol Myers Squibb Lifa Hoaxed. Pharmatalia Carlo Erba. UK Prospective Diabetes Study. Glucose Control Study. Blood Glucose Control Study, aims to determine whether improved glucose control of type 2 diabetes will prevent clinical complications. Therapy with sulfonylurea, first or second generation. Insulin. Metformin. Has any specific advantage or disadvantage? Patient characteristics. 5,102 newly diagnosed type 2 diabetic patients. Age 25 to 65 years, mean 53 years. Gender male, female 59, 41%. Ethnic group Caucasian 82%, Asian 10%. Afro-Caribbean 8%. Body mass index mean 28 kg/m2. Fasting plasma glucose, FPG, median 11.5 millimoles/L. B1C median 9.1%. Hypertensive 39%. UK Prospective Diabetes Study. Follow-up of patients to major fatal and non-fatal clinical endpoints. Recording of surrogate endpoints, clinical and biochemical markers, for example urine albumin, retinol photographs, visual acuity. Intention to treat analysis. Randomization. 14%. FPG, fasting plasma glucose, mol/L. UK Prospective Diabetes Study. Does an intensive glucose control policy reduce the risk of complications of diabetes? Randomization of treatment policies. 342 allocated to metformin. Conventional policy 30%, N equals 1138. Intensive policy 70%, N equals 2729. Sulfonylurea N equals 1573. Insulin N equals 1156. Main randomization N equals 4209, 82%. 3,867. Treatment policies in 3,867 patients. Conventional policy N equals 1,138. Initially with diet alone. Aim for near normal weight, best fasting plasma glucose less than 15 mmol/L, asymptomatic. When marked hyperglycemia develops, allocate to non-intensive pharmacological therapy. Treatment policies in 3,867 patients. Intensive policy with sulfonylurea or insulin. N equals 2,729. Aim for fasting plasma glucose less than 6 mmol/L, asymptomatic. When marked hyperglycemia develops on sulfonylurea, add metformin, move to insulin therapy on insulin, transfer to complex regimens. Actual therapy. The 1C. Cross-sectional, median values. Change in body weight. Cross-sectional, mean values. Hypoglycemic episodes. Self-reported at each clinic visit. Assessed by clinician to determine severity. Graded as minor, treated by patient alone. Major, requiring third-party assistance. Grade of most severe episodes recorded. All major episodes audited from clinical records. Hypoglycemic episodes per annum. Actual therapy analysis. Any diabetes-related endpoint. 1,401 of 3,867 patients, 36%. First occurrence of any one of diabetes-related death. Non-fatal myocardial infarction, heart failure or angina. Non-fatal stroke. Amputation. Renal failure. Retinal photocoagulation or vitreous hemorrhage. Cataract extraction or blind in one eye. Any diabetes-related endpoint, cumulative. 1,401 of 3,867 patients, 36%. Diabetes-related deaths. 414 of 3,867 patients, 11%. Any of fatal myocardial infarction or sudden death. Fatal stroke. Death from peripheral vascular disease. Death from renal disease. Death from hypoglycemia, diabetes-related deaths, cumulative. 414 of 3,867 patients, 11%. Microvascular endpoints, cumulative. Renal failure or death, vitreous hemorrhage or photocoagulation. 346 of 3,867 patients, 9%. Myocardial infarction, cumulative. Fatal or non-fatal myocardial infarction, sudden death. 573 of 3,867 patients, 15%. Aggregate clinical endpoints. Progression of retinopathy. Two-step change in early treatment diabetic retinopathy study, ETCHRS, scale. Microalbuminuria. Urine albumin greater than 50 mg/L. Glucose control study summary. The intensive glucose control policy maintained a lower HbA1c by mean 0.9% over a median follow-up of 10 years from diagnosis of type 2 diabetes with reduction in risk of 12% for any diabetes-related endpoint p equals 0.029. 25% for microvascular endpoints p equals 0.0099. 16% for myocardial infarction P equals 0.052. 24% for cataract extraction P equals 0.046. 21% for retinopathy at 12 years P equals 0.015. 33% for albuminuria at 12 years P equals 0.000054. Conclusion. The UPTs have shown that intensive blood glucose control reduces the risk of diabetic complications, the greatest effect being on microvascular complications. UK Prospective Diabetes Study. Does insulin or sulfonylurea therapy have specific advantages or disadvantages? Sulfonylurea therapy. Advantages. Known to improve glycemic control. Stimulates endogenous insulin production. Disadvantages. In the heart, sulfonylurea mimics ATP and may prevent vasodilation in ischemia. First-generation agents may increase arrhythmia. Insulin therapy advantages. Well-used therapy to improve glycemic control. May be essential for many patients. Disadvantages. Need for injections. Risk of weight gain and hypoglycemia. Raised insulin levels may promote atherosclerosis. Randomization comparison between 3 intensive therapies. Compare each with conventional policy. The 1C. Cohort, median data. Change in weight. Cohort, mean data. Hypoglycemic episodes per annum. Actual therapy analysis. Blood pressure. Cohort, mean data. Any diabetes-related endpoints. CVG-VIP equals 0.36. Myocardial infarction. CVG-VIP equals 0.66. Progression of retinopathy, 2-step change. Favors intensive. Favors conventional. Sulfonylurea or insulin, summary 1. All 3 therapies were similarly effective in reducing the 1C. All 3 therapies had equivalent risk reduction for major clinical outcomes compared with conventional policy. In those allocated to chloropropamide, there was equivalent reduction of risk of microalbuminuria but no reduction of risk of progression of retinopathy. Sulfonylurea or insulin, summary 2. Sulfonylurea therapy. No evidence of deleterious effect on myocardial infarction, sudden death or diabetes-related deaths. Insulin therapy. No evidence for more atheroma-related disease. UK Prospective Diabetes Study. Does metformin in overweight diabetic patients have any advantages or disadvantages? Introduction. The UPTs have shown that an intensive glucose control policy using sulfonylurea or insulin therapy is effective in reducing the risk of complications in both overweight and normal weight patients. Overweight, greater than 120% ideal body weight, UPTs patients could be randomized to an intensive glucose control policy with metformin instead of diet, sulfonylurea or insulin or sulfonylurea 951. Randomization. Main randomization 4209. Non-overweight 2505. Overweight 1704. Conventional policy 411. Intensive policy 1293. Insulin or sulfonylurea 951. Metformin 342. Patient characteristics. Overweight patients greater than 120% ideal body weight after 3 months diet therapy. Age mean 53 years. Gender male, female 46%, 54%. Ethnic groups Caucasian 86%. Asian 6%. Afro-Caribbean 8%. Body mass index mean 31 kg/m2. Fasting plasma glucose median 8.1 mmol/L. The 1C mean 7.2%. The 1C. Overweight patients. Cohort, median values, change in weight. Overweight patients. Cohort, mean values. Hypoglycemic episodes per annum. Overweight patients. Actual therapy analysis. Any diabetes-related endpoint. Overweight patients. MVCP equals 0.0023. MVIP equals 0.0034. Diabetes-related deaths. Overweight patients. MVCP equals 0.017. MVIP equals 0.11, myocardial infarction. Overweight patients. MVCP equals 0.010. MVIP equals 0.12. Microvascular endpoints. Overweight patients. MVCP equals 0.19. MVIP equals 0.39. Metformin comparisons. Overweight patients. RR, 95% C. Favors metformin. Favors conventional. Metformin comparisons. Overweight patients. RR, 95% C. Favors metformin or intensive. Favors conventional. Sulfonylurea plus metformin. Patients primarily randomized to intensive therapy with sulfonylurea were not given additional metformin until their FPG was greater than 15 mmol/L or they developed hyperglycemic symptoms. In view of the progressive hyperglycemia in these patients, a protocol modification was made to secondarily randomize the subset of patients who were on maximum sulfonylurea therapy and had FPG greater than 6 mmol/L to earlier addition of metformin, AIM. The aim of this secondary randomization was to assess the degree to which glycemic control might be improved by early combination therapy with metformin. In view of the interesting results in the primary metformin study, a secondary analysis was undertaken to examine any endpoints that had occurred. Aggregate endpoints. Interpret with caution in view of small numbers, 26 deaths on sulfonylurea plus metformin versus 14 deaths on sulfonylurea alone. Metformin in overweight patients. Compared with conventional policy, 32% risk reduction in any diabetes-related endpoints P equals 0.0023. 42% risk reduction in diabetes-related deaths P equals 0.017. 36% risk reduction in all-cause mortality P equals 0.011. 39% risk reduction in myocardial infarction P equals 0.01. Metformin, summary. The addition of metformin in patients already treated with sulfonylurea requires further study. On balance, metformin treatment would appear to be advantageous as primary pharmacological therapy in diet-treated overweight patients. Blood pressure control study. UK prospective diabetes study. Blood pressure control study. Blood pressure control study aims to determine whether tight blood pressure control policy can reduce morbidity and mortality in type 2 diabetic patients. ACE inhibitor, captopril, or beta blocker, atenolol, is advantageous in reducing the risk of development of clinical complications. Inclusion criteria. Patients not on antihypertensive therapy systolic greater than 160 and or diastolic greater than 90 mm of mercury. Patients already on antihypertensive therapy systolic greater than 150 and or diastolic greater than 85 mm of mercury. Excluded if required strict blood pressure control, severe illness, contraindication to study medication or declined informed consent. Patient characteristics. 1,148 type 2 diabetic patients. Age 56 years. Gender male, female 55%, 45%. Ethnic groups Caucasian 87%. Asian 6%. Afro-Caribbean 7%. Body mass index 29 kg/m2. B1C 6.8%. Systolic, diastolic blood pressure 160, 94 mm of mercury. Urine albumin greater than 50 mg/L 18%, randomization. Blood pressure, type versus less type control. Cohort, median values. Less type control. Mean blood pressure MHG baseline mean over 9 years. Less type control 160, 94 154, 87. Tight control 161, 94 144, 82. Difference 1, 0 10, 5. PNF less than 0.0001. ACE inhibitor 159, 94 144, 83. Beta blocker 159, 93 143, 81. Difference 0, 0 1, 1. PNF P equals 0.02. Therapy requirement. Any diabetes-related endpoints. Risk reduction 24% P equals 0.0046. Diabetes-related deaths. Risk reduction 32% P equals 0.019. Myocardial infarction. Risk reduction 21% P equals 0.13. Stroke. Risk reduction 44% P equals 0.013. Microvascular endpoints. Risk reduction 37% P equals 0.0092. Heart failure. Risk reduction 56% P equals 0.0043. Progression of retinopathy, two-step change. 243, 461, 207, 411, 152, 300, 20, 40, 60% patients. 23, 37, 28, 51, 34, 3 years, 6 years, 9 years. P equals 0.38. P equals 0.019. P equals 0.004. Years from randomization. Numbers above bars are percent affected. Deterioration of vision, 3 lines on MedDRS chart. 293, 575, 257, 523, 180, 332, 10, 20, 30, 7, 5, 9, 8, 19, 3 years, 6 years, 9 years. P equals 0.40. P equals 0.47. P equals 0.004. Percent patients. Years from randomization. Numbers above bars are percent affected. Urine albumin greater than 50 mg/L. 317, 618, 274, 543, 166, 299, 10, 20, 30, 40, 24, 18, 29, 33, 3 years, 6 years, 9 years. P equals 0.008. P equals 0.052. P equals 0.33. Percent patients. Years from randomization. Numbers above bars are percent affected. Blood pressure control study. In 1148 type 2 diabetic patients a tight blood pressure control policy which achieved blood pressure of 144, 82 mm of mercury gave reduced risk for any diabetes related endpoint 24% P equals 0.0046. Diabetes related deaths 32% P equals 0.019. Stroke 44% P equals 0.013. Microvascular disease 37% P equals 0.0092. Heart failure 56% p equals 0.0043. Retinopathy progression 34% p equals 0.0038. Deterioration of vision 47% p equals 0.0036. UK prospective diabetes study. Do ACE inhibitors or beta blockers have any specific advantages or disadvantages? Blood pressure, ACE inhibitor versus beta blocker. Cohort, median values. Less tight control ACE inhibitor beta blocker. Reasons for non-compliance. Any diabetes related endpoint, cumulative. 429 of 1,148 patients. 37%, diabetes related deaths, cumulative. 144 of 1,148 patients, 13%. Microvascular endpoints, cumulative. Renal failure or death, vitreous hemorrhage or photocoagulation. 122 of 1,148 patients, 11%. Aggregate clinical endpoints. Surrogate endpoints relative risk in 99% C favors ACE inhibitor. Favors beta blocker. Conclusion. ACE inhibitors and beta blockers were equally effective in lowering mean blood pressure in hypertensive patients with type 2 diabetes and in reducing the risk of any diabetes-related endpoint. Diabetes-related deaths. Microvascular endpoints. Potential implications for clinical care of diabetic patients. UK prospective diabetes study. Potential implications for clinical care of diabetic patients. UK prospective diabetes study. An intensive glucose control policy HbA1c 7.0% versus 7.9%. Reduces risk of any diabetes-related endpoints 12% p equals 0.030. Microvascular endpoints 25% p equals 0.010. Myocardial infarction 16% p equals 0.052. A tight blood pressure control policy 144, 82 versus 154, 87 mm of mercury reduces risk of any diabetes-related endpoint 24% p equals 0.005. Microvascular endpoint 37% p equals 0.009. Stroke 44% p equals 0.013. Choice of therapies diabetes. Each of the available therapies studied can be used. In overweight, diet-treated patients, metformin may be advantageous. Hypertension. Beta blockers and ACE inhibitors each provide protection. Which goals of therapy? Current guidelines suggest HbA1c less than 7%. The risk of diabetic complications was reduced in the UCTS trial, which achieved a median HbA1c 7.0% in the intensive glucose control group. This HbA1c level is in accord with current guidelines but is difficult to accomplish in some patients. Epidemiological analysis suggests that any reduction of hyperglycemia would be advantageous. Which goals of therapy? Current guidelines suggest blood pressure less than 140, 85 mm of mercury or less than 130, 85 mm of mercury. The risk of diabetic complications was reduced in the UCTS blood pressure control trial, which achieved a mean blood pressure 144, 82 mm of mercury in the tight control group. This result is in accord with current guidelines, which are also supported by the epidemiological analysis. Polypharmacy glycemia. Combinations of agents with different actions will be needed. More patients will require insulin. Blood pressure. Many patients will need 3 or more different types of agents. Differences between therapies. Sulfonylurea, insulin and metformin are each effective in reducing the risk of any diabetes-related endpoints and microvascular endpoints. No evidence of increased risk of complications for any single therapy. ACE inhibitors and beta blockers are each effective in reducing the risk of macrovascular and microvascular endpoints. No evidence that either is specifically advantageous. UK Prospective Diabetes Study. The UKs have shown conclusively that intensive therapy to reduce glycemia is worthwhile as it reduces risk of complications. Tight blood pressure control is worthwhile as it reduces risk of complications. There are no major differences between the therapies tested. Reduction in risk of complications of diabetes is a realizable goal. Beneficial effects of intensive therapy. The UKs have shown that more intensive monitoring, more intensive use of existing therapies, which improves blood glucose control, blood pressure control, can reduce the risk of diabetic complications.